Hi, it's Dr. Terry. This is a audio recording that is meant to accompany the team-based learning activity for neurodegenerative disorders. You're welcome to listen to this as a standalone audio activity, kind of like a podcast, or this can accompany the slides in the pre-work. In this discussion, we're going to be covering 7 distinct learning objectives, but really they're the same learning objective with different pathologies. That learning objective is to describe the pathogenic mechanisms and the clinical presentation of patients with various disorders. The disorders that we'll be covering in this talk include Alzheimer-type dementia and other amyloidoses, Parkinson-type dementia, Huntington's chorea, amyotrophic lateral sclerosis and other TDP-43 proteinopathies, multiple sclerosis, tauopathies, and synucleopathies. We'll also be discussing normal pressure hydrocephalus. Let's begin with Alzheimer-type dementia. Alzheimer-type dementia, or Alzheimer's disease, is the most common cause of dementia in older adults, and its incidence increases as age increases. The disease usually becomes clinically apparent as insidious impairment of higher cognitive functions. As the disease progresses, we see deficits in memory, visual-spatial orientation, judgment, personality, and language that gradually emerge. Over the course of 5 to 10 years, the affected individual becomes profoundly disabled. They may become mute, they may become immobile. Things like eating, toileting, and even breathing no longer become a priority. Alzheimer's is a complex disease that involves much more than just memory. Although pathologic examination of brain tissue obtained at autopsy remains necessary for a definitive diagnosis, a combination of clinical assessment and current radiologic methods allow for accurate premortem diagnosis in 80 to 90% of cases. Let's talk about the pathogenesis. The fundamental abnormality in Alzheimer's is the accumulation of 2 proteins. Those proteins are beta amyloid and tau protein in specific brain regions. These protein accumulations likely occur as a result of excessive production and defective removal of these proteins. The 2 pathologic hallmarks of Alzheimer-type dementia, particularly evident in end stages of the illness, include first, neurotic plaques, and second, neurofibrillary tangles. The neurotic plaques are deposits of aggregated amyloid beta peptide. Neurotic plaques are focal, spherical collections of dilated, tortuous, axonal, or dendritic processes, often around a central amyloid core. The lesions that are termed diffuse plaques are found mainly in superficial portions of the cerebral cortex, the basal ganglia, and the cerebellar cortex. This is in contrast to neurofibrillary tangles, because the tangles are actually aggregates of the microtubule binding protein tau, which develop intracellularly and then persist extracellularly after neuronal death. If we look at gross specimens of brains both with Alzheimer-type dementia and those without, the brain that carries Alzheimer's disease is going to show variable cortical atrophy, marked by narrowing of the gyri and widening of the sulci. This is most pronounced in the frontal, temporal, and parietal lobes. Because of the significant atrophy that occurs in the cortex, we see compensatory ventricular enlargement secondary to the reduced brain volume. This is especially evident in the medial temporal lobe, which involves the hippocampus, which is involved with memory, the entorhinal cortex, and the amygdala, possibly resulting from some of the inappropriate and complex emotional changes that happen in people with complex disease. Those areas in the medial temporal lobe, the hippocampus, the entorhinal cortex, and the amygdala, are involved actually early in the disease process, and then by later stages of the disease, they are severely atrophied. The clinical progression of Alzheimer's disease is slow but continuous. Initial symptoms include forgetfulness and memory disturbances, but with progression, we see other symptoms emerge. This includes language deficits, loss of mathematical skills, and loss of learned motor skills. In the final stages, affected individuals may become incontinent, mute, and unable to walk. In many cases, other associated conditions, such as pneumonia, become the terminal event, as basic functions like breathing and swallowing become more difficult, or, at a minimum, less of a priority for a brain that is not functioning as well as it did before. In the slide set, I mention other amyloidoses and include a chart of a list of other amyloidoses, such as Creutzfeldt-Jakob disease, Gertzmann-Strauss-Lurch-Scheinker disease, familial British dementia, and of course, Alzheimer dementia. In each of these, we see protein aggregates that include amyloid protein. I'd like you to be responsible for knowing other diseases by name But of these, Alzheimer's is the one that is most common and the one that you're most likely to see clinically. One that is worth mentioning on the list is that of Creutzfeldt-Jakob disease, specifically in knowing that this disease is caused by abnormal protein accumulation called prions, and these prions are not killed by standard methods for sterilizing surgical equipment. As prions accumulate in cells, the brain slowly shrinks, and the tissue fills with holes until it resembles a sponge. That's one of the reasons why this disease and other spongiform encephalopathies related to prions are named similarly. Moving on, we're going to talk for a bit about Parkinson's disease or Parkinson-type dementia. Parkinson's disease is a neurodegenerative disease marked by hypokinetic movement disorder that's caused by loss of dopaminergic neurons in the substantia nigra. Those are two key elements in needing to identify and establish the pathophysiology of Parkinson's. Parkinson's is specifically about that loss of dopaminergic neurons in the substantia nigra. In Parkinson's, we do see protein accumulation and aggregation, similar to an Alzheimer's, but of a different protein, and mitochondrial abnormalities, as well as, again, neuronal loss in the substantia nigra. The hallmark of Parkinson's disease are Lewy bodies, which are accumulations of the alpha-synuclein protein. The clinical syndrome of Parkinsonism includes at least 4 different distinct features. The first of those is diminished facial expression, often termed masked facies, stooped posture and slowing of voluntary movement that we'll refer to as bradykinesia, and a festinating gait, which involves progressively shortened and accelerated steps to keep the person from falling over. This is combined with rigidity of muscles, as well as pill rolling, a pill rolling or resting tremor. The resting tremor is called a pill rolling tremor because it looks as if a person is rolling a pill in the fingers as they move their hand. It may affect one side more than the other. Images are frequently shown that may include a pale substantia nigra, and there may also be pathologic images of several Lewy bodies visible in sections of basophilic homogeneous cytoplasmic inclusions. Lewy bodies, again, are the hallmark of Parkinson's disease, and they're rich in that protein known as alpha-synuclein. We should also be familiar with atypical forms of Parkinson's disease, or colloquially referred to as Parkinsonism. This can be a component of many different disease processes, and these are minimally responsive to treatment with L-DOPA, or L-dopamine, and they are distinguished from Parkinson-type dementia through the presence of additional signs and symptoms. For these reasons, they're considered to be atypical Parkinsonian syndromes, or what we might call Parkinson plus syndromes. 2 of these that I'd like you to know about are progressive supranuclear palsy and corticobasal degeneration. Progressive supranuclear palsy is uncommon, and it causes problems with walking, balance, and eye movements, and later with swallowing. Corticobasal degeneration, by contrast, is a progressive neurologic disorder characterized by nerve cell loss and atrophy of multiple areas of the brain, including the cerebral cortex and the basal ganglia. Corticobasal degeneration progresses gradually, with initial symptoms beginning at or around age 60. Now, for those of you who are following for our psychiatry course that often comes in the spring, we're going to be discussing Parkinsonism as a side effect of neuroleptic or antipsychotic medications. We see Parkinsonism in patients with antipsychotic medications on board because those medications block dopaminergic transmission. That's very similar to the pathophysiology of Parkinson's disease, and now's a great time to make that connection where we see that Parkinsonism and Parkinson's disease are associated with interruptions in dopamine processing. When we have that impairment in dopaminergic transmission, we have Parkinsonism, but not necessarily Parkinson's disease. The next high-yield area for us to discuss is Huntington disease or Huntington-type dementia. If we're referring to the movement disorder, then we'd be talking about Huntington's chorea, which has choreiform movements. It's important to know that Huntington disease is an autosomal dominant disease caused by degeneration of striatal neurons and characterized by progressive movement disorder and dementia. The mutation that's on the Huntington gene is on chromosome 4, resulting in a number of CAG repeats. These expanded CAG repeats result in the accumulation of excess numbers of polyglutamine residues in the Huntington protein. It should be noted there's an inverse relationship between the number of CAG repeats and the age of onset of disease. This is to say that those with more CAG repeats will have an earlier onset of disease, and that's a critical component in the familial transmission of this autosomal dominant disease. The CAG repeats increase in number during spermatogenesis, again resulting in the disease having an earlier presentation in successive generations. This is a term that is referred to as anticipation, and is one that's well worth knowing. When we take a look at either postmortem samples or sometimes through brain imaging on live patients with Huntington-type disease, we see brains that are small with striking atrophy of the caudate nucleus and the putamen, components of the dorsal striatum. You may see atrophy secondarily in the globus pallidus, with the lateral and third ventricles being dilated due to the decreased areas of brain tissue in these areas. On microscopic examination, there's profound loss of striatal neurons, with the most marked changes again found in the caudate nucleus. So we're already seeing with Huntington-type dementia or Huntington chorea some of the connections that we'll need to be making between this being an autosomal dominant disease, the CAG repeats, anticipation across successive generations, and the marked changes that we've seen in the caudate nucleus. Characteristic clinical features include jerky, hyperkinetic, and sometimes dystonic movements involving all parts of the body that we refer to as chorea. Affected individuals may later develop bradykinesia and rigidity. Huntington's disease is relentlessly progressive and uniformly fatal. One should be familiar with how to diagnose the risk in subsequent generations. If, for example, we have an affected father who has Huntington, who carries the Huntington gene as an autosomal dominant pattern, and an unaffected mother, the probabilities of that passing on to their offspring is 1 in 2. The next disease process that we're going to take a look at is amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. Amyotrophic lateral sclerosis is a neurodegenerative condition that primarily affects motor function, manifesting with progressive weakness and muscle wasting. As mentioned, at least in the United States, we've come to identify it more commonly as Lou Gehrig's disease, named after the famous baseball player who had the disorder. This typically has an insidious onset, resulting in a long delay before a definitive diagnosis is established. The disease typically affects motor neurons in the frontal lobe and the anterior horn cells of the spinal cord. One of the things that really stands out here is that this is primarily a motor disease, whereas cognition is left intact. This is something that distinguishes it from the diseases that we have discussed earlier. Clinical symptoms related to the upper motor neuron degeneration include a loss of dexterity, slowed movements, muscle weakness, stiffness, and emotional lability. Signs on neurologic examination that confirm an upper motor neuron lesion may include a pseudobulbar affect, pathologic hyperreflexia, spasticity, and extensor plantar responses, such as a Babinski sign. We also see lower motor neuron signs and symptoms, and those are caused by the anterior horn cell degeneration. Here we see weakness, muscle atrophy, fasciculations, and cramps. Fasciculations, in the absence of associated muscle atrophy or weakness, are usually benign and may be aggravated by sleep deprivation, stress, and/or excessive caffeine ingestion. Muscle weakness in patients with ALS almost always begins distally and asymmetrically, and it may manifest as a monoparesis, hemiparesis, periparesis, or quadriparesis. Symptoms may also be limited initially to the bulbar region, resulting in difficulty with swallowing, speech, and movements of the face and tongue. Now we notice that the protein aggregate in this case with amyotrophic lateral sclerosis is TDP-43. We see this in other TDP-43 proteinopathies, such as frontotemporal lobar degeneration, primary lateral sclerosis, and progressive muscular atrophy. I would be familiar with each of those conditions as having their primary protein aggregate as TDP-43, but clinically I would be most interested in you being able to make the connections specifically with ALS. Moving on, the next disorder that we should speak about, one that is considerably more common, is that of multiple sclerosis. Multiple sclerosis, or MS, is an autoimmune disease, though its exact etiology is still not fully understood. In many people, it begins as what we would call a relapsing and remitting disease, and then ultimately becomes progressive. It's associated with perivascular infiltration of monocytes, macrophages, lymphocytes, and a variable amount of antibody and activated complement. During the progress of the disease, gray matter lesions in the thalamus and cerebral cortex are also noticed. Common presentations include optic neuritis, diplopia, myelitis, sensory disturbances, and weakness. Less frequently, we may see seizures, cognitive problems, or pain. Diagnosis is almost always by MRI, where degeneration of the myelin sheath can be recognized. If a CSF analysis is completed through lumbar puncture, we'll see elevated concentrations of immunoglobulin G and immunoglobulin M, which creates what we call oligoclonal bands. Optical coherence tomography, or OCT, is another way to image the retina and detect evidence of prior optic neuritis. You should be familiar with multiple sclerosis and how that looks on an MRI. Specifically, the axial images often show periventricular infiltrates that appear as white dots or white dashes on multiple forms of MRI that, again, are adjacent to the ventricles. Many of the MRI images that you will look at will show multiple periventricular lesions, sometimes on one side, but often bilaterally surrounding the ventricles. In the slides that accompany this recording, I do have some information on the tauopathies, the synucleopathies, and related disorders that correspond with those. For the tauopathies, we'll remember that Alzheimer-type dementia, it does include a pathological accumulation of tau proteins, but there are also other disorders that include abnormal tau accumulation. You should be familiar that the tauopathies exist and are linked to tau protein, and you should be able to, on multiple choice, identify which disorders are due to, say, tau protein versus alpha-synuclein. I'm not going to ask you too many specific questions about signs and symptoms of the specific tauopathies. Some of the items on this list that you can think about in terms of your tau accumulation include chronic traumatic encephalopathy, primary age-related tauopathy, Pick's disease that specifically affects frontal and temporal lobes, progressive supranuclear palsy, corticobasal degeneration, and aging-related tau astrogliopathy. For the synucleopathies, we remember that these focus on the aggregation of the presynaptic protein alpha-synuclein, and we see that, for example, in the Lewy bodies found in a range of clinical syndromes such as Parkinson's disease, Parkinson's dementia, and Lewy body dementia. Lewy body disorders, in general, as accumulations of alpha-synuclein, are much more common in men. Many patients may have autonomic dysfunction, sleep disorders, and psychiatric features such as visual hallucinations. A way to remember that is that in many types of our alpha-synucleopathies, we do have disrupted dopaminergic transmission, which again is something that we link psychiatrically to, in the mesolimbic system in particular, to our transmission of ideas and perceptions of our senses. So when that dopaminergic transmission is interrupted, hallucinations are common. At autopsy, there's often minimal, if any, neocortical or brainstem atrophy, and the most significant findings are usually noted when sectioning the brainstem, where there's a loss of neuromelanin pigment in the substantia nigra and the locus ceruleus. Finally, for today, we're going to talk a little bit about normal pressure hydrocephalus. Normal pressure hydrocephalus involves intermittent elevations in intracranial pressure, or ICP, despite a normal mean ICP. Sometimes this is reversible. This is not terribly common, but common enough to where it is something that you're likely to see clinically. The annual incidence is about 1 to 5 people per 1 million, and it's most commonly, again, in older adults ages 60 through 80. This may represent or may manifest itself as a subcortical dementia that includes a classic triad, sometimes called Hakim's triad, that's often referred to as a patient being wet, wobbly, and wacky as a way to remember that. The wetness refers to urinary incontinence. Wobbly refers to their apraxic, magnetic, or shuffling wide gait disturbance, and wacky may refer to slow processing, impaired executive function, or the cognitive decline and dementia that often corresponds with a subcortical dementia for a person that has normal pressure hydrocephalus. Diagnosis of normal pressure hydrocephalus is often through imaging, where we'll see disproportionate enlargement of the ventricles on the MRI or CT, and it can be confirmed if symptoms improve following high-volume lumbar puncture or continuous CSF drainage. Differential diagnosis may include many of the things that we've spoken about: Alzheimer-type dementia, Parkinson's, vascular dementia, and other causes of gait or cognitive impairment. So again, some of the things that I would be really interested in seeing if I were trying to make this diagnosis is I'd be looking for that classic triad of, say, the urinary incontinence, the wet, the gait disturbance or wobbly, as well as the cognitive decline or dementia, the wacky part. I'd also be looking at imaging, seeing if I saw enlarged ventricles without significant cortical degeneration. Treatment, not surprisingly, is really a plumbing issue in this case, where a ventriculoperitoneal shunt or a VP shunt is placed, and it's effective in appropriately selected patients. Usually those are going to be the ones who responded favorably to a lumbar puncture. Because we're running something, of course, from the ventricles into the peritoneum, we're going to need close monitoring for complications, such as infection, subdural hematoma, or even overdraining the CSF. The clinical relevance that we need to remember is that early recognition is essential when that pressure is building, because if the pressure can be relieved, it can avoid irreversible cognitive decline. I will mention, of course, because this talk is directed toward DO students, that there is a case study involving some improvement in symptoms with cranial manipulation, but I wouldn't select this as the top choice for how to resolve this issue just yet. That concludes our discussion for today on our neurodegenerative disorders. Thank you for listening, and look forward to seeing you in class.